So today I'm going to discuss about the rheumatoid arthritis, and again my presentation is related to the Mrcp basis consultation station. So let's start with our presentation. So as usual, I will have choose one case scenario for you. So this is Mrs. Smith, a 57-year-old woman, and she's complain of joint pain, especially in her hand and knee. She also reports stiffness in the morning that usually lasts for a few hours. She has noticed swelling and redness in her fingers. Her symptoms have been present for the last 6 months and have been gradually worsening. She has no significant past medical history. So again, as I told you that whenever you come across your case scenario, just look for the buzzword. So here the buzzword is joint pain is one, and then we have some stiffness in the morning and some swelling and redness in her fingers. So by this you had some idea that we are dealing with a musculoskeletal system, and most probably maybe a case of rheumatology, and rheumatoid arthritis should be on the top of the list. Let's start our so once you have read the scenario, may just make few differential diagnoses in your mind, and then you proceed with the history. So same thing, we're going to do the introduction first. In the introduction, like, hello Mrs. Smith, my name is this and I am one of the doctor here. How can I assist you today? Confirm identity may be not needed, but you can verify patient name and age. So chief complaint and presenting complaints. And so clarify the chief complaint. I understand you have been experiencing some joint pain. Could you please tell me more about it? So at this moment, the patient will volunteer all the information which she is allowed to give without prompt. Onset and duration. Then we ask, when did the joint pain start? How long have you been experiencing it? We'll ask about the progression. Has the pain worsened, improved, or remained the same since it started? We want to know about any aggravating and alleviating factors. Are there specific activities or factors that make the pain better or worse? Then after you have asked all the relevant question about the presenting complaint, we'll move to the past medical history. So we'll inquire about the chronic conditions. So we'll ask, do you have any other medical conditions like high blood pressure or diabetes? Is she taking any medications, either prescribed or over the counter? And any known allergies to medications or substances? We'll take a brief social and psychosocial history. Something like this, that could you tell me more about your daily activities and occupation? We want to inquire about the social support. Do you live alone or do you have support from family or friends? Emotional well-being. How long have these symptoms affected your mood and daily life? And we would like to review the systems as well, other systems. So I'd like to ask about other body systems. Have you experienced any changes in the weight, appetite, or energy levels? Any fever, cough, or breathing difficulties? And then we're going to summarize and we check for the understandings. To summarize, you have been experiencing joint pain in multiple areas for the last 8 months with morning stiffness and some functional limitations. We will conduct further assessment to determine the cause, and then you'll put some invite questions. Is there anything else you would like to share, or any questions you have for me? So remember this thing, that effective communication, empathy, and patient-centered approach, these are crucial during the Mrcp PACES examination. So practice the active listening and show genuine concerns for the patient well-being. So once you have done the history, then going to proceed with the examination. So same thing, already you have done your introduction. So this one I have put, if you come across this case in the short case, like maybe you can get this case in the any other short case, maybe they can put it there. So examination approach for introduction, obviously we give greet Mrs. Smith courteously, introduce yourself, confirm her identity, obtain consent for the examination. So how you will proceed with the examination, we start with journal inspection. So observe Mrs. Smith's journal appearancing, noticing any sign of distress, fatigue or discomfort. We want to check for any pallor, jaundice or any visible deformities such as joint abnormalities or rheumatoid nodules. So these are important things which you should do in your journal inspection, which you should observe. Then we'll go to hands and upper extremity examination. So hands, look for any swelling, warmth, any tenderness or deformities, and then palpate the metacarpophalangeal and proximal interphalangeal. These joints you palpate for any sign of swelling and tenderness. In the wrist and elbow, assess for swelling, tenderness, and limited range of motion, and look at the nails, inspect nails for any pitting, onycholysis, or other signs of psoriatic involvement. So after you've done the hands and upper extremity examination, you proceed with the lower extremities, look at the knees and ankle, inspect for any signs of inflammation, redness, swelling, or any effusion, palpate the knee joint for the warmth and tenderness, and also look at the feet to examine for any deformity, swelling, or ulceration, and pay attention to the metatarsophalangeal joints. Then you look at the skin, look for any rheumatoid nodules which are common in rheumatoid arthritis. These nodules are often found over the external surface. Ask about symptoms of dry eyes or any recent visual changes, and obviously refer to an ophthalmologist if necessary, especially if there are signs of Sjogren's syndrome. Then you will do briefly the respiratory examination, ask about any respiratory symptom, check for signs of pleuritis, such as pleuritic chest pain, but remember, this can be subtle. Respiratory system examination, you're just going to do the chest expansion and make it short. So chest expansion and auscultation should be enough. Psychological assessment, inquire about her mood, stress, and coping mechanism. Chronic conditions like obviously rheumatoid arthritis, they can significantly impact the mental health. Conclusion, thank Mrs. Smith for her cooperation and summarize your findings briefly. This one we can discuss the next steps, such as further investigation, referral to a specialist if needed, and always remember this to maintain a respectful and empathetic attitude throughout the examination, ensuring that the patient feels comfortable and understood during the process. So this is briefly about the examination. This is just an example actually. You can alter it and you can do it whatever routine you are following. The important thing is don't miss any positive findings. Okay, so what are the differential diagnoses of this patient? Patient present with joint pains. First of all is rheumatoid arthritis, and then we want to look for any rheumatoid arthritis complication like rheumatoid nodules, rheumatoid vasculitis. Rheumatoid vasculitis can cause skin ulcer, nodules, or digital infarcts. Felty syndrome, which is characterized by rheumatoid arthritis, splenomegaly, neutropenia, and recurrent infection, and anemia of chronic disease, and secondary Sjogren's syndrome. It's common in rheumatoid arthritis patient present with dry eyes and mouth. Other autoimmune or inflammatory arthritis, we'll be thinking about psoriatic arthritis, is in the differential, especially if there are nail changes or history of psoriasis, and ankylosing spondylitis, if there are symptoms related to spine or sacroiliac joint. We'll be thinking about SLE also, joint pain. It presents with joint pain, skin rashes, and systemic symptoms are common. And gout, attacks of acute arthritis due to this is due to deposition of uric acid crystals in the joint. So these are the other autoimmune or inflammatory arthritis we should consider. Then other differentials include infections like septic arthritis or osteomyelitis. So these two also can, but normally if there is in rheumatoid arthritis we have small hand joints involvement, so these becomes less likely actually infections. Degenerative joint disease like osteoarthritis, common in older adults, causing joint pain and stiffness. Endocrine and metabolic disorders, hypothyroidism can cause joint pain, stiffness, myopathy, and diabetes Diabetes, also long-standing, can lead to joint issues. Neoplastic conditions like multiple myeloma, it can also cause joint bone pain and joint symptoms. Metastatic bone disease, cancer mets to joints or bones, and neurological disorders like peripheral neuropathy. It also can cause sensory disturbances and pain in extremities. So I put so many differential diagnoses there, but important differential diagnosis to consider will be psoriatic arthritis, SLE, ankylosing spondylitis, gout, and degenerative joint disease. Others, if you remember, is okay. What about the investigations, approach to investigations? Again, I have divided into laboratory tests and imaging studies. And so in the laboratory tests, we want to look for rheumatoid factor and anti-CCP, anti-cyclic citrullinated peptide antibodies to confirm the diagnosis of rheumatoid arthritis. We also like to do the CBC to assess for anemia and other abnormalities. We want to check the inflammatory markers like CRP and ESR because elevated level indicates active disease. Liver and kidney function test to assess the overall organ health, and urine analysis to check for any signs of kidney involvement or urinary infection. ANA, anti-nuclear antibody, to rule out autoimmune diseases like SLE. We want to do the thyroid function test to rule out thyroid disorder, serum uric acid level, to rule out gout, blood cultures, well, if there is any suspicion of septic arthritis, and immunoglobulin level to assess the immune status. What about the imaging studies? We will want to do the X-ray to assess the joint damage, erosions and narrowing. Ultrasound can detect synovitis, joint effusion and erosions. We can do the MRI, which provides the detailed images of the soft tissue and joint, and DEXA scan to assess the bone mineral density, especially in the post-menopausal women, considering the Mrs. Smith age. Joint aspiration or synovial fluid analysis. Aspiration of a joint can be performed to analyze synovial fluid for signs of infection, inflammation or crystals as in gout. So laboratory test, imaging studies, and joint aspiration synovial fluid analysis if needed. But joint aspiration normally you do if this is a monoarthritis. If one big joint is involved, then you can do the joint aspiration. And so again depends on the in the rheumatoid arthritis that which joints are involved, how many joints are involved, and then you can alter your laboratory test and imaging studies accordingly. Then we have specialized tests like HLA-B27 if these are symptoms suggesting ankylosing spondylitis or other related conditions. We can do muscle enzymes as well, such as creatine kinase if there are symptoms suggestive of myositis. And we want to do the ECG and echo if there are cardiac symptoms or a history of cardiovascular disease. So what should be the management approach? Management approach, remember, always divided into the pharmacological intervention and non-pharmacological intervention. So in pharmacological interventions in the management of rheumatoid arthritis, disease-modifying anti-rheumatic drugs, and this methotrexate, often the first-line choice. It reduces inflammation and slows the joint damage. Sulfasalazine, hydroxychloroquine, leflunomide, these are alternative disease-modifying anti-rheumatic drugs and used alone or in combination with methotrexate. Then we have biologic disease-modifying anti-rheumatic drugs like TNF factor inhibitors or interleukin-6 inhibitor, and these are considered for moderate to severe cases when traditional DMARDs fail. Non-steroidal anti-inflammatory drugs, they're also okay for symptomatic relief from pain and inflammation. Corticosteroids, it can be used short-term during flares to rapidly reduce the inflammation. We have to give some pain reliefs like we can give acetaminophen for pain control. Gastroprotective agents like PPI to prevent NSAID-induced gastritis and osteoporosis prevention by giving the supplements like calcium and vitamin D, and bisphosphonates if indicated due to prolonged steroid use. What about the non-pharmacological intervention? We can do the physiotherapy, strengthening exercises, and joint range of motion exercises to improve mobility. Occupational therapy, which actually is assisting with the adopted devices and techniques for daily activities. Weight management, we want to maintain a healthy weight to reduce stress on joint. Low impact activities like swimming and walking to maintain joint flexibility. Heat and cold therapies, application of heat or cold packs to alleviate the pain and stiffness, and patient education. Understanding the disease, its course, and the importance of adherence to medications. Patient needs regular monitoring, so we want the patient to attend his appointments regularly. Appointment, regular appointment with a rheumatologist for disease assessment and medication adjustment. Laboratory monitoring, we want to monitor the complete blood count, liver function, renal function, and markers like CRP and ESR. And maybe sometimes we have to do the periodic X-rays and other imaging studies to assess the joint damage progression. Some patients are for surgical intervention, and the options include synovectomy, which is removal of the inflamed synovium if limited to certain joints, and joint replacement. Total joint replacement for severely damaged joints, so it helps to improve the mobility and relieving pain. And patient needs some psychological support as well because of this, because of the rheumatoid arthritis. So we can do counseling, addressing the emotional aspect and coping strategies, and participation in support groups can provide emotional assistance. Finally, patient education is very important in this. We should emphasize the lifestyle modifications like exercise, rest, and joint protection techniques. Medication adherence, so importance of taking medication as prescribed, and we'll also educate about any red flag symptoms. So educate about signs of disease flare-up or complications requiring immediate medical attention. So Mrs. Smith management actually should be individualized based on disease severity, response to treatment, comorbidities, and preferences. So a collaborative approach is needed, something we call it multidisciplinary approach. So we need help from the rheumatologist, physiotherapist, and other healthcare professional for optimal disease control and enhancing her overall well-being. So you have some idea about the history, and you have done the examination, then you already know your differential diagnosis and your most likely diagnosis, then how you will present the case. Again, I have divided into different sections. First of all, we're going to do the introduction. So good morning, my name is this and I am a medical doctor. I have the consent of Mrs. Smith, a 58-year-old lady, to present her case to you today. Mrs. Smith presents with symptoms suggestive of rheumatoid arthritis. So you can tell the diagnosis straight away that what is your most likely diagnosis. After introduction, you're going to continue with your presentation by giving some brief history. Mrs. Smith is a 58-year-old female who presented with 6-month history of joint pain, swelling, and stiffness, predominantly affecting the small joints of her hands and feet. She describes morning stiffness lasting for more than an hour. She has noticed decreased grip strength, leading to difficulty in performing daily activities like buttoning her clothes. There is also a history of fatigue and intermittent low-grade fever. She denies any recent infection or trauma. So once you have described the history, you're going to continue and talk a bit about the past medical history. So Mrs. Smith has a history of hypertension, well controlled on amlodipine, and occasional use of ibuprofen for her joint pain. There is no history of diabetes or other autoimmune disorders in the family. So this was all about the brief history. Continue your presentation and talk a bit about the examination. On examination, this is just one of the example. Mrs. Smith appears fatigued. She has synovitis in the proximal interphalangeal and metacarpophalangeal joints of both hands. They are also swollen and tender metacarpophalangeal joints bilaterally. Morning stiffness is present for more than an hour. She has no skin rashes, oral ulcers, or eye symptoms. So you're going to tell about the important negatives as well. Cardiovascular, respiratory, abdominal, and neurological examinations are unremarkable. Continue with your presentation and suggest some investigations. Mrs. Smith blood, if the investigations are already available to you, otherwise you just suggest. So Mrs. Smith blood test shows elevated CRP and ESR and positive rheumatoid factor and anti-CCP. X-ray of her hands reveals erosions and joint space narrowing consistent with rheumatoid arthritis. So this you will say if you already have the information. If you don't have, then you just suggest these investigations. And then you will come to the diagnosis. So based on the clinical representation, examination finding and investigation, Mrs. Smith is diagnosed with seropositive rheumatoid arthritis. And then we're going to talk a bit about the management in our presentations. So something like this, Mrs. Smith will be initiated on disease-modifying anti-rheumatic drugs such as methotrexate to control disease activity and prevent joint damage. She will also be prescribed NSAID for pain reliefs. Regular follow-ups with the rheumatologist are planned to monitor her progress and adjust the treatment as necessary. Mrs. Smith will receive patient education on joint protection, exercise, and the importance of medication adherence. And finally, you will summarize. So in summary, Mrs. Smith, a 58-year-old lady, presents with a 6-month history of joint pain, swelling, and stiffness affecting her hands and feet, consistent with seropositive rheumatoid arthritis. She will be started on disease-modifying anti-rheumatic drugs and will have regular follow-up with the rheumatologist. Thank you. So this is how once you're doing the presentation, remember these headings so that you don't miss anything. Start with your history, past medical history, examination, investigations, diagnosis, management, and summary. Okay, so let's move on. So there are some questions which are quite common in this case, and the examiner may ask you. What are the diagnostic criteria for rheumatoid arthritis? So this is one of the answer. So the diagnostic criteria for rheumatoid arthritis is as per the 2010 American College of Rheumatology and European League Against Rheumatism classification include the presence of synovitis, at least one joint, absence of an alternative diagnosis that better explains the synovitis, and a total score of 6 or greater out of 10 based on criteria including joint involvement, serology, acute phase reactant, and duration of symptoms. In Mrs. Smith case, she meets these criteria with positive rheumatoid factor, anti-CCP antibodies, and characteristic joint involvement. Another question which could be asked is, what are the treatment options for rheumatoid arthritis and what factors influence the choice of therapy? So, the treatment options for rheumatoid arthritis include disease-modifying anti-rheumatic drugs like methotrexate, sulfasalazine, and biological agents such as TNF inhibitors. The choice of therapy is influenced by factors such as disease severity, presence of poor prognostic factors, for example, positive rheumatoid factor or erosions, comorbidities, and patient preference. In Mrs. Smith's case, considering her positive rheumatoid factor and anti-CCP antibody, she will likely to be started on methotrexate as a first-line disease-modifying anti-rheumatic drug. Another question which could be asked, what are the potential complications of uncontrolled rheumatoid arthritis? Well, uncontrolled rheumatoid arthritis can lead to several complications, including joint deformities, disability, and decreased quality of life. It also results in systemic complications such as cardiovascular disease, osteoporosis, and increased susceptibility to infections due to immunosuppressive therapy. Early and aggressive management of rheumatoid arthritis is crucial to prevent these complications. Another question is, how do you monitor the effectiveness of treatment in rheumatoid arthritis? So the effectiveness of treatment in rheumatoid arthritis is monitored through clinical assessment, including the joint examination for signs of inflammation and tenderness. Additionally, lab tests such as ESR and CRP are used to measure inflammation level. Imaging studies like X-rays and ultrasound can assess joint damage and synovitis progression. Patient-reported outcomes, including pain and functional status, are also important indicators of treatment response. Okay, there are a few other questions which are commonly asked. What are the side effects and monitoring requirement of methotrexate therapy? So methotrexate is a commonly used disease-modifying anti-rheumatic drug in rheumatoid arthritis. This can cause side effects like hepatotoxicity, myelosuppression, and pneumonitis. So patients who are on methotrexate, they require regular monitoring, include complete blood count, liver function test, and renal function test. Periodic assessment for signs of infections and lung infection may also be necessary. So how do you manage a flare-up of rheumatoid arthritis symptoms? So during a flare-up of rheumatoid arthritis, the management involves optimizing the current DMA-ARD therapy using non-steroidal anti-inflammatory drugs or glucocorticoids for symptom relief, and potentially adjusting the dose or switching DMRDs if necessary. Close monitoring of disease activity, joint examination, and appropriate investigation guide the management decision. Okay. And finally, what are the criteria for considering a patient for biological DMRD therapy in rheumatoid arthritis? So remember, patients with rheumatoid arthritis may be considered for biological DMRD therapy if they have high disease activity despite adequate treatment with at least 2 conventional disease-modifying anti-rheumatoid drugs, including methotrexate. So this is one of the indication. Then other one is other factors such as the presence of poor prognostic markers, intolerance to conventional DMRD, or significant functional impairment can also influence the decision to initiate the biological therapy. So this is all about rheumatoid arthritis. I have tried my best to cover almost everything which is needed for your MRCP consultation station. If you came across rheumatoid arthritis case, if you think that something is missing or how to improve it, just put in the comments, and we will continue with our presentations, and I will see you in my next presentation. Thank you very much, and take care of yourself.